All right, on to the show, Season 3, Episode 8. Enjoy.
My guest today is Dr. Theo Ispoglou, a reader in nutrition and muscle health at Leeds Beckett University. He has a keen interest and expertise in studying the effects of nutritional and exercise interventions as a means to optimize human performance. In particular, identifying evidence-based strategies to prevent, minimize, or treat sarcopenia, as this is an important public health priority given the increasing number of older people. Doc, really appreciate you carving out some time today.
Hi, Mark. Thanks for the introduction. And thanks, first of all, for inviting me for this podcast interview. I feel humbled to have been invited and appreciate greatly your interest in my work.
Fantastic, Theo. Well, listen, I appreciate you coming on, and I'd love to start things off here by perhaps you telling listeners a little bit more about your background and how you came into this line of research.
Okay, my pleasure. I have a background in sport and exercise science, and many years ago I completed my first degree in Greece before I moved to UK to complete a master's degree and then subsequently a PhD. And in terms of my personal interests, I have been a sprinter, a coach. I have worked in the fitness industry for many years before I moved to UK. So for me, it's really important application of knowledge. It has always been one of my priorities. So I had a personal interest, and then I wanted to know more and more, and then I got into science. And to cut a long story short, I'm really interested in studying the effects of nutritional exercise, nutrition and exercise interventions on human performance, how to optimize performance, whether it's sports, whether it's everyday life. And in recent years, my focus has shifted on studying how nutrition and exercise can address muscle weakness in older people.
Terrific. I mean, definitely a topic that with the baby boomer generation getting older, sarcopenia is obviously a really important topic, and one that I definitely see in my clinical practice quite often, and something that, as like yourself, if you have a background in sort of sport or whatnot, you realize how important this can be to help fight this off. So maybe you can start by giving listeners a definition. Can you define sarcopenia?
Absolutely. To start with, just to make, you probably are aware of this, but for most people are not aware that there are about 8 different definitions of sarcopenia. So there is no consensus worldwide on the definition of sarcopenia. However, the original definition by Rosenberg, 1989, it focused on muscle mass. And the focus was also a reduction in muscle mass with aging. So it was the age-related sarcopenia. Then that definition developed further and it introduced strength as well. So it was a reduction in muscle mass and strength with aging. It's not applicable just to aging, but we'll come back to this. And after years, 2010, the European Working Group in sarcopenia in older people did some great work and placed more emphasis on function as well. So we started with muscle mass, and over the years we moved on strength and function. So if you wanted a title, a brief title that the majority of people could understand, I would say the age-related sarcopenia is a reduction in muscle mass and strength with aging. That's the most widely used definition for sarcopenia, but there are more definitions, and that's what causes some challenges that I think we should talk about it later today of how to diagnose sarcopenia.
Absolutely, and you mentioned obviously important to define the age-related being sort of the most common one, and definitely something that as people get over the age of 50 starts to become more of a concern. But could you perhaps talk about some of the other common causes of sarcopenia?
Yes, sarcopenia. Key causes. If we exclude age and disease, because disease it can be a main cause of sarcopenia. Physical inactivity, disuse, if you like, and nutrition inadequate nutrition are key contributing factors to sarcopenia. So the more physically inactive we are, the more likely to suffer from sarcopenia. And we don't have to be older people to suffer from sarcopenia. There may be someone may be a couch potato, or someone may have suffered an injury, or for whatever reason, lifestyle changes, etc. They may have a sedentary lifestyle for an extended duration. That could result to sarcopenia. And then it's anorexia, diet. If we don't eat enough, and we don't eat enough protein in particular, again, that's a key contributing factor to sarcopenia. And if you think about it, if we focus on muscle, and now I'm going to move a little bit back. I'm going to talk with my sports science hat, if you like, here. When it comes to muscle, and when I teach to my students, I talk to the students about the importance of muscle growth for force-generating capacity. And typically, and that's not, as you know very well, bigger muscles doesn't necessarily mean stronger. But if we manage to increase muscle size, for most cases, that will be associated with an increase in muscle strength. So we increase... So we need to achieve that. So how do we achieve that? We need to be in positive energy balance, and we need to be in positive nitrogen balance. We can increase our body weight or the size of our muscles, let's say, if we are in energy balance, or if we don't get enough nutrients. How are we going to rebuild this muscle? And what's really crucial here is protein, dietary protein, because dietary protein will provide you with the essential amino acids that the human body cannot make them. And these are the building blocks of muscle mass. So really, if you want to optimize rates of muscle protein synthesis, muscle growth, we need to have adequate protein, high quality protein that provides you with all the essential amino acids. The non-essential amino acids, they're not as important as the essential amino acids. And you also need to be in energy balance. We need to eat enough, because otherwise, even if you get more protein, that protein, if you don't get enough food, enough energy, that protein will be oxidized, will be used for other purposes, to maintain other bodily functions. I know I can, hopefully I answered your question.
Yeah, absolutely. That's fantastic. And Theo, to give people a frame of reference here, let's say for age-related sarcopenia, after the age of 50, what type of losses in strength are we seeing potentially on average year after year?
Okay. This will vary, but typically you would expect 40, 50, I would say from even earlier, from the age of 40. About 1% per year muscle losses, but that could be much higher if you're physically inactive. So the more physically inactive, the more likely that the losses will be greater. The reductions in strength can be even greater, but that's been attributed to some of the techniques that's being used as well. Some researchers have shown that actually some of the methods we use, assessment, body composition methods, may not fully reflect the losses in muscle strength, if you like. But typically you would expect about 1% in muscle mass, a bit more in strength. And then the more physically inactive you are, the bigger it gets.
Terrific. And Doc, obviously you've done a lot of work in this area. If we circle back to the nutrition front, and protein being such a key part of all this, essential amino acids, particularly things like leucine, to facilitate, as you mentioned, not only protein but also total energy intake. Can you walk listeners through some of your recent work and highlight some of the key findings for folks?
Okay. Yeah, of course. We have what we did. We completed a few years ago. We completed a study where, rather than using protein, we used essential amino acids enriched with leucine. It was a supplementation. It was a study, a pilot study on older people over the age of 65, on older people. So we wanted to see what happens if we try to give them essential amino acids enriched with leucine. Now, leucine, I haven't talked about leucine yet, but leucine is the most important amino acid because this is crucial for optimizing rates of muscle protein synthesis. It's like a switch, if you like. So now, if you don't get enough leucine, and there are lots of mechanistic studies, acute studies, where where others have looked at the rates of muscle protein synthesis acutely, and you can see clearly the impact that leucine has when it's removed. So you remove leucine, so rates of muscle protein synthesis are decreased to a dramatic extent. On the other hand, I would never suggest to anyone use leucine on its own. For leucine to be of benefit, it needs to be in the presence of other essential amino acids, whether it's from the diet and whether if there is a need for supplementation, from supplementation. And I'm talking to you about this study in older people, but I'll take you back. My first paper in 2011, we looked at the impact of leucine supplementation over a 12-week period in younger individuals. So they followed a resistance training program over a 12-week period, and the sessions were all supervised. But leucine was given alongside the meals. We were, at the time, what we knew is that leucine is important. So what happens if we give them leucine, approximately 4 grams daily, split into 2 dosages, and they take it alongside their meals? And because there was lots of emphasis at the time for the post-exercise period, the importance of maximizing rates of muscle protein synthesis during the post-exercise period. The days they were exercising, they got the supplement, the extra leucine during immediately post-exercise. Yep. We do know nowadays, it's been more research coming into light, and we do know that timing is not as important as we used to believe in the past. But it's still, I wouldn't say have a huge gap and then get the nutrients after. I would never recommend that to anyone. So the point I was making was that it's important that leucine amino acids, leucine is either being supplemented in the presence of other amino acids or alongside food, so you can get the essential amino acids, so you can get the best out of leucine. And this study in older people, it was 3 months, it was only a supplementation intervention. We did show some significant gains in functional performance of older people. What we did is also we used 2 essential amino acid mixtures. One had 20% leucine and the other one had 40% leucine.
Interesting.
Yeah. And that was the 20% amino acid mixture. More or less, that would be a reflective of the amino acids ratio composition, let's say, in a whey protein supplement, which in a sense that's in a whey protein isolate, I would say the best available source of protein. If someone asks me what is the best high quality protein source, if we look into supplements, I would say whey protein isolates. So that standard essential amino acid mixture was more reflective of the ratio in a whey protein isolate. The 40% was enriched with leucine because we know that older people need more. There is quite a bit of research on the area that older people need more leucine as a means to enhance muscle protein synthesis. We become more resistant, if you like. As we get older, we become less efficient to responding to anabolic stimuli. And in the case of leucine, we do know that older people need to have higher leucine in the diets. And you can achieve that by eating high quality protein sources. You need to ensure that you get in good high quality protein so you can get adequate amounts of leucine. And that study, both groups showed improvements in functional performance of the amino acids, but the leucine group had demonstrated also some significant gains in lean tissue mass compared to baseline. Yes, there were lots of limitations, as it happens with many real life studies, research. But that was the start from us. Now, why you use amino acids? I don't think I have answered this question to you yet. The reason we didn't use protein is there is quite a bit about protein, and we do know that protein is the most satiating macronutrient. It makes you feel fuller, which is great if you try to lose body weight. It makes you full, and that's why lots of high protein diets do work quite well. And we know with athletes in moderate energy deficiencies, we increase protein intake as well. That helps with the satiety, helps with the maintenance of muscle mass as well. But for certain populations, that may not be an advantage, that may be a disadvantage. Because older people, many older people, especially those in clinical settings, in care home settings, they suffer from protein energy malnutrition or undernutrition. So basically, they're not eating enough. So if we try to give them protein, we may solve that problem, but we may exacerbate the other.
Yeah, it's such an important point, Theo, because the classic sort of tea and toast diet as people get older, appetite goes down. Mm-hmm. Things like tea will start to suppress appetite, or even if they do drink a little bit of alcohol, that can suppress appetite. And now all of a sudden there's just not enough food going in. And as you mentioned, bigger boluses of protein could be definitely beneficial. But then obviously if it's impacting appetite or they can't get through it, I mean, this is a really novel spot and a potentially important spot for supplementation.
I think we still need a bit of more work to do in the area, and we're doing now a number of PhD students here. We have planned to look at long-term effects. This is what happens acutely. We don't have studies, long-term studies. They haven't compared. And we do know that in general, people with higher protein intakes, they are healthier. They do better when it comes to clinical outcomes, etc., quality of life. So we do know that. But we don't know what would have happened. In certain cases, there has been, I definitely need to mention that in clinical settings, there have been many cases of caloric redistribution. What I've just mentioned is less likely to happen in healthy individuals or older individuals who tend to have good appetite levels, especially if they're physically active. But in clinical settings, there have been studies where they give them a supplement, but then they end up eating less. We don't want that.
Important point.
We don't want a supplement. We want a supplement to be a supplement. We don't want it to replace the diet. And that's always the message we try to get across to our students. It's first of all the diet. You try to get this right. And when there is a need of supplementation, make sure that doesn't have a negative effect on the quality of diet. And yes, in some, I can provide you with references if you want me to, but we do know that's been observed in clinical settings in particular. So that's why we use essential amino acids. We thought, okay, let's see what happens. Plus, it was easier for us to manipulate the ratio of amino acids. But we didn't know whether acutely what happens, actually what we've just hypothesized. Is this what actually happening? If we give them amino acids, our hypothesis was that if you give them those amino acids, their appetite won't be negatively affected. And that's where we moved to our next research project. So we did, and that's been, it's been published, this paper. So we look at the acute effects of essential amino acid nutritional prototypes on appetite and energy intakes and macronutrient intakes when the supplements were taken either just immediately before an ad-lib breakfast or 1 hour before an ad-lib breakfast. So in a sense, we did 2 experiments. We had 6 conditions for this research. And there was one condition which was a standard, the control. So basically one day the people came to our lab and we asked them to eat as much as they could. So then we measured how much they ate. So we recorded protein intake, energy intake, etc. And so we had a clear picture, of how much they can eat habitually. And
Gotcha.
The second condition was we used a gel which had 7.5 grams of essential amino acids at the 40% ratio that we used in the previous study. Why 7.5 grams? 7.5 grams of essential amino acids, that's roughly, if you want to take 7.5 grams of these amino acids from a high quality protein source, you would need to get about just over 15 grams of protein. Let's say more than half a liter of milk, which is quite substantial.
For
and
sure.
with regards to the protein recommendations, for older people currently, the intakes are about 25 to 30 grams, or if you prefer relative terms, I would say 0.4 grams per kilogram of body mass, at least, which is more than what we're recommending for younger individuals. So in absolute amount, let's say a younger person, around 20-25 grams on average now, because of a bigger person, or you need much more protein. On average, it would need about 20-25, an older person more likely to need around 30. And now lots of epidemiological studies have shown that the problematic meals during the day, if I can use the word problematic, it's the breakfast, perhaps lunch. Breakfast, people hardly take any protein, no more than 10 grams. So let's say 10, if you add the 7.5 grams, let's say equivalent of about 15, in a sense you help them hit the protein intake recommendations per meal. We're not only helping people achieve the daily protein recommendations, but we're helping them achieve the protein intake per meal, the recommended protein.
Very important, yeah.
So we did that, and we did show that actually when they had the gel, there was hardly any impact on appetite. So more or less, there was no significant difference between, if you looked at the amount of food they had at the breakfast alone, when they had the gel, we used the bar as well, and we compared it with the control. More or less, they ate about the same amount of food at the breakfast. But then you add some extra energy from the gel and the bar, and we managed to achieve an increase both in protein intake and energy intake, which is really important for certain populations, especially clinical care home settings. So,
yeah, I mean, it's such an important point, as you mentioned previously. I think a lot of people forget, if they don't work in the space of nutrition or clinically, that older populations are going to require greater amounts of protein, as you mentioned, sort of that resistance, anabolic resistance. And I know Stu Phillips' work around suggesting that even the RDA for protein, rather than being the 0.8 grams per kilogram per day, raising that up to 1.2 in older populations. I'm wondering your thoughts on that.
Yeah, absolutely. Stuart and his group have done an amazing work, and I totally agree with him. There is a need. We have to increase that 0.8. I'm shocked actually that the 0.8 is still out there. People think that the 0.8 grams is adequate. There have been studies in the Prodigy studies, and there is lots of research keeps coming through, and it's not just from Stuart's group. They have done lots of work, but we know probably 1.2, even 1.5, maybe more appropriate for older individuals. So I'll give you an example here. Let's say that we know that think of a person that needs to hit 30 grams of protein per meal. They need about 3 meals a day. That's 90 grams of protein. If we go with a 0.8 grams and someone is 50, 60 kilograms, there is no way you're going to hit that. So you're not hitting the optimum protein intake per meal. So if we approach it that way. So really, in order to achieve the protein intake recommendations per meal, the 0.8 grams is not sufficient. And also, as we get older, we tend to suffer more from, they're more likely to suffer from low-grade inflammation. They're more likely to be inactive, etc. We become less anabolic. We develop anabolic resistance, etc. So there is a need. We need to eat more protein. With a 0.8 grams of protein, the majority of people they're not going to hit. They're not going to achieve their needs. It's not going to be optimum to maintain good muscle health and ultimately good muscle function, which in turn will result to good quality of life. So I would say, about 1.2, definitely. We have to raise the 0.8 grams, and we need to ensure that we hit this, the protein intake per meal. Because what may happen, let's say, what happens during the day, there is variation in rates of muscle protein synthesis. We're constantly breaking down our body proteins, and we're resynthesizing. We make new proteins, new muscle in particular. And the critical period is the postprandial period after we eat. So if we, let's say, and we do know that breakfast is suboptimum, people don't eat enough at breakfast. So very soon after that, there will be rates of protein synthesis expected not to be optimally increased. And then very quickly afterwards, they will be in a catabolic state, negative nitrogen balance, until the next meal. So during that period, ultimately what you're doing is you're using your own muscles. You're eating your own muscles. And if,
Absolutely,
let's say,
yes.
and if you do that, it may not be a lot. That may be over, let's say, over a year. Someone may not be eating enough at breakfast. So, more or less, we know they won't be eating enough at breakfast. I'm even struggling to eat enough at breakfast. I'm thinking, I know I'm teaching people, I'm preaching, but I'm like, I need to change something now. Realize that I'm not getting enough protein at breakfast. So I need to change the type of foods.
And it's tricky, Doc, for the general population as well. Until recently, the bit of fear-mongering around the consumption of eggs has sort of negated the one protein-rich food that was typically a staple of breakfast, and so it's really been working against folks for the last sort of 3 decades or so, would you say?
Yes, exactly. And then there was the kidney. Yeah, let's not go there.
Yeah, exactly.
I think you need to interview Stuart Phillips on that.
Yeah, we had Dr. Jose Antonio on a few seasons ago as well. If people want to circle back to that, if they have questions around the protein in kidneys, he's definitely gone through that as well as Stu.
Yeah. And just to finish that point. So if you eat, let's say, muscle protein synthesis is not optimized after breakfast and after lunch, assume that you lose about 0.5 kilogram over a year. That may be the impact of doing that. Over a decade, that could be 5 kilos. We're talking about a lot of muscle here, and we know how difficult it is to gain muscle. You don't gain it as easy as you lose it. And the same happens even with hospitalization. And there have been some amazing studies. Lee Breen and Van Loon have done some amazing studies where they reduced step counts, and you could see within a week or two there is a huge reduction in muscle mass and strength. But then we do know how difficult it is to get it back.
Absolutely. And Doc, if we shift gears here a little bit to talk about potentially patients or clients who are getting older, how can people, if they're at home listening in, how do they start to know if they're at risk of accelerated age-related muscle loss? And potentially, what are some of those common tests that might be done to assess these folks?
Okay. I've been talking to practitioners recently and in clinical practice, and I realized one of the tests that they widely use is the hand grip strength.
Yep.
So it is a practical test. And there isn't much you can do within a clinical setting. Hand grip strength and body composition are important. And these definitions for sarcopenia, they usually involve some sort of strength, a measure, muscle, body composition measure, and function. That could be gait speed, how fast you can walk, chair stand-up test, 6-minute walk test, etc. So there is no consensus right now. Usually people, when they find out that they suffer from sarcopenia, it's usually too late. And I think for me what's really important is prevention. To identify when people are at risk of being diagnosed with sarcopenia. I mean, the European Working I think if anyone wants to read more on that area, a bit more detail, there has been a systematic review by Mayhew just last year that was published. And the European Working Group in sarcopenia on older people, they've just published the revised definition for sarcopenia. But typically what you're going to do is, if we look at the European Working Group definition, because there are 8, according to that review by Mayhew, depending on which definition you use, you may diagnose between 9 to 40%. So there is huge variation, which is like, now, what do we do now? There is no consensus here. If I use one definition, that's going to tell me that I'm not sarcopenic. The other one is going to tell me I am. Which one am I using? And the good thing is that more emphasis has been placed on strength. Hand grip strength, but more recently, and that's really important, lower body strength. I think more work needs to be done on lower body strength, choosing the right practical tests that you can use for assessment of lower body muscle strength. And in men in particular, there's been research showing that men in particular, the reduction in lower body muscle strength can be greater than women. So lower body strength is better, and it's better when you look at monitoring the impact of exercise training interventions. You need some sort of measure of lower muscle strength as well and function. I would say hand grip strength on its own is not adequate, even though it's used widely in clinical practice. Body composition, a DEXA scan it's one of the test that is widely used, and it's reliable, valid, and can give you some good information about upper body lean tissue mass and lower body tissue mass. The next best alternative, we could say it's bioelectrical impedance, and for most people, they could do that. They could use that tool. Of course, you always need to make sure you control the impact of confounding variables to ensure that what you're getting actually is reflecting what happened. But yeah, strength, muscle mass, and function. There are these sort of tests that they need to do. And there are cut points that they can refer to for diagnosis of sarcopenia. The European Working Group, what they do is, they look at low muscle strength. So let's say if you have a low muscle strength, and then you have either a low muscle quantity or low physical performance, then you're diagnosed as sarcopenic. If you have low muscle strength, low muscle quantity, and low physical performance, then you would diagnose someone as severely sarcopenic.
Gotcha.
So we need some sort of those. Yeah, we've done some work. I think I'm not going to share that with you yet, but we've got some exciting
good teaser for coming out. Good.
We have another paper currently. We just did some minor revisions for this journal, but we looked at muscle quality. So rather than just looking at sarcopenia, we used the definition of muscle quality, the one used by Cooper. So basically, we have it's the ratio of strength divided by lean muscle of the relevant muscle group. So we looked at muscle quality for upper body and muscle quality of lower body. There are cut points for older people for upper body, but not for older body, lower body. But we tested 100 individuals. There were 50 younger, 50 older. So for this paper, we created our own, if you like, for the lower body. And what we realized, we used two definitions to diagnose sarcopenia. Based on the paper by Mayhew, you use the one definition that gives you the lower diagnosis and the one with the highest diagnosis. and we identified only 2 people as sarcopenic out of 100, which is not a lot. Muscle quality in older people, 40% of them had low muscle quality. To me, that tells us something, and we need to do more into that. For preventative, we're talking about more about for prevention. So I think we need to start looking more into muscle quality, not just strength, and muscle quantity moving forward. So muscle quality alongside sarcopenia, I think they can work quite well. The current definitions, I think they're great. They're good. They're more likely they will pick up people who are in clinical settings, frail people. But isn't it a bit too late by then?
Yeah, not quite sensitive enough, right?
You don't even need to do a test.
Yeah, you could just, the eyeball test works then, right?
Yeah, sarcopenic or frail. So yeah, we're moving more a bit to muscle quality, and we're trying to look how we can have a practical tool that most people can use and quickly identify someone with low muscle quality, because muscle quality can affect. There is a good association between muscle quality and functional decline.
Yeah, absolutely, and such a key area, and key to have some of those more sensitive tests and markers, as you mentioned. And Doc, you've obviously talked about protein and the importance of meal intakes of protein for preventing age-related sarcopenia, as well as daily totals. On the exercise front now, we're talking testing here, but if clinicians, practitioners, coaches, even, recreational exercisers, people who want to maintain mass as they age, on the exercise front, in your opinion, from walking all the way up to resistance training, where are some places that people can make some tangible gains?
Mm-hmm. Yes, exercise. There are recommendations out there. More or less, people heard them. Whether they apply them in practice or whether they understand what this means, that's another story. But the recommendations are there. The 150 minutes of moderate activity and the strength exercises on 2 or more days a week. Mm-hmm. Now, moderate, what's moderate aerobic activity? It's just people interpret that differently. And for someone who's more physically active, brisk walking may not be moderate enough, if you know what I mean.
Absolutely.
Yeah. Cycling, brisk walking, you need to do some sort of moderate aerobic activity. But I think it's reassuring that more people becoming aware, and that's what I personally and many colleagues of mine are trying to do here, is to make more awareness of the issue, sarcopenia, which is been recognized as a muscle disease now. It has its own ICD code, at least in America. Mm-hmm. The importance of strength, resistance, strength-promoting exercises, it is in the recommendations. People should be doing more strength-promoting exercise. It's important, but I don't think we're emphasizing it a lot.
Yeah, I was going to say the emphasis isn't quite there yet, is it?
Yeah, I think there has to be more work to be done on that area. 2 or more days a week that work all the major muscles. But there can be variations. You don't have to do. How many people do 30 minutes? If you just look at the 150 minutes. I know many people they can't do the 30 minutes of brisk walking. Older people, they're afraid in the winter to go out. They're afraid of going out and walking in case they slip and they fall, they fracture, which that will result into hospitalization, etc. But it's important to do whatever they can.
For sure. I think sometimes that 150 minutes can almost intimidate a lot of people as well. It just seems a bit overwhelming to think of that amount of effort and time. And it's definitely encouraging to see things like in Dr. Caballo's lab as well at McMaster.
The
20 seconds. Everyone's got 20 seconds, right?
Yeah. It is. And there are other benefits as well, cardiovascular. So it's not, so you have the strength. And then there is the other thing. I know, again, this is more from the sports science background, the adaptations. When we look at the adaptations to exercise, resistance type exercise or endurance type exercise. This is more likely to be an issue if someone is highly trained at the upper end of the spectrum. So someone who's doing lots of, let's say they've just started, they're not that fit, even some sort of aerobic activity, it will have some strength adaptations, and it won't have a counteractive effect on some sort of strength if they do some sort of strength training program, because there is always that concern for athletes. Oh, when do I do resistance type exercise? Because that may counteract the adaptations,
the interference effect,
etc. Interfering, I'm going, but it doesn't really that matter if you're at the initial stages, and most people, the majority of people,
not concerned really.
So I would say, you need to emphasize more strength-promoting exercise, whether that's out in the garden, digging your garden, lifting some weights, home-based exercise, going for long walks, uphill, trekking, etc. Because, or if people can go to the gym, it's important to do a lot more on that area to emphasize the importance of strength-promoting exercise.
Theo, I appreciate you carving out some time here today and fantastic insights here. So before we wrap up, last couple of questions for you. The first is on the evolution of research in this area. Where do you think things are headed in the next 5 or 10 years?
From my experience, I realized that at last clinicians, they understand how we can help them, how sports science knowledge that's been applied for years in sport performance in athletes could actually be applicable to clinical settings. And there have been very promising studies, prehabilitation interventions before surgery as a means to improve clinical outcomes. So I think there's going to be much more work on prehabilitation, rehabilitation, interventions of either exercise or exercise plus supplementation, because sarcopenia, lots of patients, especially in cancer, there is lots of those people suffer from sarcopenia and frailty, and they are undernourished and malnourished. So really, if we use exercise and someone is undernourished and malnourished, actually you're not going to achieve the best outcome. So you really need to bring nutrition as well in order to enhance the effect of exercise. So I think there's going to be more and more on that area. And this is something that I personally have an interest in, and I feel like I'm moving towards too. And I just hope, again, the point I make about the strength promoting exercise, I think people need to become more aware of the importance of resistance type exercise, strength promoting exercise, as a means to increase their health span, not just the lifespan. We've managed the humanity. We've been great. It is a success. The fact that we live so many years. We live longer, but we really need to live those years in good health. I would want that for myself and all the people. My family. Definitely. And my loved ones. So I think I would.
Yeah, it's fascinating stuff. I mean, as you mentioned, as humans, we just evolved to be able to do a lot of these things and these movements and be able to maintain some of the strength. And when you look at these older populations in the blue zones, they tend to be obviously very physically active. So love the line of research that you're in here, and look forward to a lot of great stuff coming out of your lab as well. And, Theo, the last one here for people listening in, what's one piece of advice that you might give a patient, a practitioner, even a doctor, to helping to support someone fight off age-related sarcopenia?
Okay. It will sound cliche, but keep moving. Really, if you don't lose it, if you don't use it, you will lose it. Nice. And also, maybe a second tip is try to get enough high quality protein, especially at breakfast. Make sure you eat enough high quality protein, at least at breakfast.
Fantastic. Terrific insights. Theo, appreciate you taking the time here today. Where can people stay connected with you and keep up with all your fantastic research?
They can follow me on Twitter. or they can send me an email. They can find that on my webpage if they check my universities on the university's website. I work at Leeds Beckett University, Carnegie School of Sport in UK, so you can find my details there. So I'm happy, if anyone is interested into my work or